Right, let's get going. Hi, everyone. So thank you so much for joining us for the AccuRx and UHL webinar today, where we'll be talking about validating your referral time to treatment waiting lists in weeks and taking control of elective recovery. And so just to run through, we'll do kind of an introduction to ourselves and AccuRx. We have Sandy and Amy who are joining us from UHL as well for the webinar, run through kind of the work that we've been doing with them around waiting list validation, and we'll leave time for questions at the end. So if you do have any questions, please do pop them in the Q&A. We do have a few people that will be answering questions as we go. So we'll leave plenty of time for that at the end. I think someone just raised their hand. James, go ahead. Oh. Here we go, James. I saw that you just raised your hand. Oh. No? Okay, in that case, let's get going. So a little bit of an introduction. So my name's Satya. I'm the VP of Clinical here at AccuRx. I've been at AccuRx for about 4 years. My background is paediatrics, so very much kind of secondary care focused. And then I've overseen kind of a lot of our growth in acute trust, as well as lots of other NHS services that are used by AccuRx, so GP practices, care homes, pharmacies, hospices. And I work very closely with kind of our internal teams to drive the use of AccuRx across those care settings and making sure our products are safe and valuable to our users. I'll hand over to Amy and Sandy to introduce themselves.
Hi, my name's Amy Geary. I'm an improvement lead at University Hospitals of Leicester. I work mainly on outpatient transformation, working very closely with Sandy Martin and very closely with the AccuRx team.
And I'm Sandy Martin, improvement lead at UHL.
Thanks, Amy and Sandy, for joining us. You will also see that we've got Rosie and Grattan, who don't have their cameras on and have their microphones off. They're our partnerships leads at AccuRx, and they will be helping us to answer questions in the Q&A. So like I said, please do pop them there. We will have plenty of time for any questions that anyone has at the end. So just for those of you who may not be familiar with AccuRx, we are a software company that is building a communication platform for integrated care systems. And so our vision is really for a health system where everybody involved in a patient's care can communicate, and that includes the patients themselves. And that's work that we've been doing very heavily across primary care and now expanding into kind of more of the acute sector as well. We have a very uncontroversial mission, but we know that communication can be really challenging across the NHS, and ultimately that impacts patient care. So we spend a lot of time with frontline staff, both shadowing clinics, attending outpatient appointments, going to GP practices, sitting with the admin staff, sitting with GPs. And we know that a lot of that time is spent communicating either to patients or about patients with other healthcare professionals to try and coordinate that care. So, for example, asking for the patient's last blood test before their outpatient appointment, or seeing if their diabetes is well controlled in order for them to be able to move ahead in the surgical pathway, asking for advice and guidance about third-line treatment for a patient's uncontrolled blood pressure, or just simply communicating test results and keeping the patient in the loop about what's happening with their referrals or where they are in those care pathways. And we often see that communication can be incredibly fragmented. So healthcare professionals don't have the information they need to make a decision. Patients don't feel well informed about their care, and that results in huge inefficiencies in the system. And that ultimately impacts both the ability and experience for healthcare staff who are very pressed for time, who are carrying a huge cognitive load to do their job well, as well as impacting the patient experience. And the thing that we hear repeatedly from patients is that it doesn't feel like a joined up national health system because they're having conversations with their primary care doctor or GP. That's not being translated when they get to the hospital or their community services. So that communication makes it harder to feel like it's one national health system working together. And so we really built software. We built software that helps anyone working in the NHS across any care setting. So like I said, we're used by GP practices, acute services, community and mental health trusts. We're used by ambulance services, pharmacies, care homes, everywhere that communication around a patient or to a patient happens. We have kind of usage in across lots of those services. And the bread and butter of what we do is really SMS messaging. prescribing. So we initially started life as a antibiotic clinical decision support tool to support prescribing. And actually we found that there was a part of the product that allowed messaging. And that was a piece that was really picked up by healthcare professionals in order to communicate with patients. And then we thought that would be used for things like giving information about side effects of antibiotics, but actually started to be used in lots of other ways. So we first built the ability for GP practices to message patients, sending digital documents or digital leaflets, or requesting a response back from the patient. So a text or photo response, for example, when somebody had a skin lesion or an injury that they wanted reviewed. We then made it easier for patients to message their GPs or submit an online consultation. So that's patients contacting the practices to say, I would like to be seen, or I need a repeat prescription, or I've got the symptoms and it's getting worse. We've since added the ability for healthcare professionals to collect structured data back from patients. So that might be questions about their asthma symptoms, and that helps GP practices meet their cough targets. Or it might be things in secondary care where we're redesigning referral pathways to get earlier structured data back from the patient about their symptoms in order to then be able to direct them to the most appropriate next step in that referral process. So lots and lots of different scopes. That we've also now allowed, historically we've always built the healthcare questionnaires in-house. Now we've released that functionality to all our users so they can build their own questionnaires. And what that does is really allow them to determine the most appropriate care for that patient, reduce the need for face-to-face interactions for more simple administrative queries. And we've consolidated that now through building a patient portal. So that's a single place where a patient can view and engage with any healthcare professional that's involved in their care, from the GP to the clinical nurse specialist in the hospital, as well as see what's being communicated about their care. If they wanted to and they have an annual asthma review, they could go back and see how their asthma is progressing year on year through those reviews as well. So a centralised place where patients can both engage with their care as well as remain well informed about what's happening to them. And by building that functionality, spending lots and lots of time with NHS staff and patients and trying to solve the real needs on the ground, we're now in this incredibly privileged position where Accurx is used by 98% of GP practices every week and 68% of NHS trusts across acute community mental health and ambulance trusts by more than 350,000 NHS users. And we've been used to deliver care for 58 million unique patients. And just to give you kind of a for that to feel less abstract, that's just over 80% of the British population that have been contacted using Accurx. And so patients are very familiar now to engaging about their care in this way. We're also supporting elective recovery, and this is what we're going to talk about in a bit. So through our partnership with UHL, we've removed 20,000 patients from the waiting list, typically saving staff on average 5 hours a week. And we send those clinical questionnaires, we send over 340,000 of them week on week. But why are we talking to you all? So what we want to discuss today is the work that we've done with UHL and how we've deployed a communication platform really quickly across the trust that's allowed us to see results that are supporting elective recovery. We know that trusts have been asked by NHS England to have a plan in place by the 30th of September to tackle overwhelming backlog of outpatient appointments, which existed before COVID but has been exacerbated by COVID, and to complete the validation of over 12-week waiters by that date. So in the next 9 months or so, NHS England have also said that they want trusts to validate their entire waiting list, reduce all waiting times to below 65 weeks, and reduce outpatient follow-up appointments. And there's no way that we can do that without deploying very simple solutions that within our existing capacity. So we know this won't come as a surprise to many of you who've joined, and it's likely to feel like a daunting task. 31st of October is only 6 weeks away. RTT lists are larger than ever, and there's unprecedented disruption that we're seeing across the system. So waiting list management has become incredibly complex and resource intensive. And those traditional methods that trusts are typically relying on just can't keep up. So things like phoning patients, asking patients, going via the GP and then patients having to circumvent and try and contact the service themselves to know what's happening. Digital solutions historically have added lots of complexity to that process and take months to implement and deploy, let alone then to start to see the results. But we've managed to kind of turn that on the head. So we very much believe that digital tooling and transformation support can help control waiting lists, and it can be deployed across the NHS quickly. And so you can start to see those operational benefits in a matter of weeks. And there are really three key levers that we see tech can support trusts to manage their elective backlog. So the first of those is with administrative validation, so ensuring your waiting list is kept up to date and there's good data quality around patients that are waiting to be seen. The second step of that is clinical waiting list validation, so prioritising patients through clinical need and urgency through simple triaging. And the third one is really digital patient-initiated follow-up, so reducing the volume of unnecessary and routine face-to-face appointments and giving patients better control of their care. So we're going to talk more in detail about the first two today. So we'll talk through administrative waiting list validation and then clinical validation and the work that we've done with UHL. We will also just touch on digital patient-initiated follow-up, or PIFU, briefly, but do feel free to ask us about it afterwards. Very happy to answer questions about any of this. So our first lever is admin-led waiting list validation and enabling you to keep your waiting list up to date. So through simple batch messaging functionality, you can contact patients at scale who are still waiting to be seen quickly and easily. Then collate those patients and find out who does or doesn't still need to be seen, including if they don't want to be seen, reasons why they don't want to be seen. Also helping to resolve any data quality issues. So some of the work that we have seen through the work we've done with UHL is it helps to identify patients who have been incorrectly added onto the waiting list, who've already received care elsewhere and their symptoms are now resolved, and also those patients who still need to be seen. And we've seen that you can see results very quickly. So I'm going to hand over now to Amy and Sandy to explain how that works and the impact that's had at UHL.
Hi, so UHL, it's the fourth largest acute trust in the country. And since COVID, our waiting list grew by 85%. So it's probably one of the most challenging trajectories of all the acute trusts. We also had a high number of DNAs and we had a high number of cancellations on the day. So our teams were really struggling to get on top of the waiting lists. They highlighted this as a real issue. So basically, we are also short on our admin teams, as I'm sure other trusts. So basically, we partnered with Accurx to try and see if we could do things a bit more effective. Do you want to carry on? Oh, sorry.
Yeah, no problem.
Next slide.
Please, Satya, sorry.
Okay, so what we started doing was sort of like October, November time. We started just with a few services, just sending them text message. Do you still want your appointment? Yes or no? The patients just replied yes or no. We at that point, I think our response rate was about 50%, but we were still getting quite a lot of patients removed from our waiting list. We were working closely with Accurx, and Accurx gave us batch messaging option, which was then allowed us to do the validation at scale. So you can see sort of December time, we were literally contacting our whole RTT waiting list within a day. And so that was like all of our services at UHL. And the Accurx, they've got a behavioural scientist who she'd tweak the wording of the text message, and they also gave us a flurry. So instead of just sending the patient a message saying, do you want your appointment, yes or no, they had a questionnaire to fill in. So when the patients replied to the questionnaire and they said they didn't want their appointment, we then asked a further question, can you let us know why? Whether it was if it was no, it was, do you want to be seen? It was, okay.
Oh, no, that's fine. So our patients were asked if they still required to see the service that they were under. And the graph shows the RTT waiting list, and as you can see, it started to decline as soon as these messages were sent out and responded to. And it significantly started to drop from November. we're now trying to aim this to become business as usual within the process, within the services. But currently, it's running centrally, just so we can manage it and see if it's actually continuing to be effective. The way we're rolling out with this is every 9 weeks we touch base with our PTL, our patient target list, and we contact those patients every 9 weeks. The project's expanded over 67 services across UHL now, because Accurate system requires little training, and further spread across the trust, and it's become more straightforward to us. So our aim now is for the services to lead on this, to put their own twist on it, and to make it work even more for their service and their patients. Next slide, please, Satya. So our patient and staff feedback has been really positive. Staff have reported an improved experience and morale as a result of their workload decreasing, and it being more effective within their workflows. They've said that they use the text messages has transformed their workflows more widely and made communication with their patients a lot easier. For our patients, waiting list validation has proved much needed reassurance and improved the overall patient experience. Rather than feeling left in the dark about their care, we are now directly communicating with our patients who are overdue for their appointments. This helps reassure our patients that while they are still waiting and been waiting a long time, they have not been forgotten by us and are still very much a priority of ours to get them seen as quickly as possible. Thank you.
Well, thanks, Amy and Sandy. And I realise I may have skipped slides, so I might show you the one. Apologies, thinking in moving across. I want to talk a little bit more about kind of the second lever here, so clinical waiting list validation to triage patients to the most appropriate care pathway. So this is an example of some of the work that we've been doing here. So we've been working with the colorectal team at University Hospitals Leicester, UHL, to redefine that kind of referral pathway for patients that have been referred the first time with rectal bleeding. So through co-development of a structured clinical questionnaire to capture symptoms and risk factors for patients, we're now cohorting patients by risk and moving them on to the most appropriate next step. So also helping to reduce that kind of unnecessary face-to-face appointment. So for some eligible patients, that may mean moving on directly to diagnostics rather than a face-to-face review. For others, that is a face-to-face review first. And the most important thing here is it's not kind of just being signed off the back of the questionnaire. We still feel very strongly patient preference is incredibly important. So we're also asking patients what their preference is in those pathways to take that into account. So you can see that below kind of which percentage of patients, so 36%, roughly about a third moving direct to diagnostic tests, a third having appointments first, and kind of the remaining third saying essentially they have no preference. So by doing this work, we've removed a further 5% of patients from the waiting list, and also avoided up to about 10% of first face-to-face appointments by kind of directing patients to diagnostics or face-to-face care more appropriately. We're also working with UHL and other trusts to support this clinical validation at scale. So, for example, part of some of the national work around perioperative care, we're working with a trust to identify and move eligible patients to new high-volume, low-complexity hubs that are being set up nationally, so that patients who are low complexity can kind of move on to surgery there. So lots and lots of kind of work going on there in the background to do that clinical triaging. And the aim really of this is working directly with services. So we find that obviously with the best will, patient pathways are often quite linear, but actually patients move in squiggly ways all through those pathways and have different drop-off points throughout that funnel. So really trying to optimize for the care delivery, whilst also optimizing for what's the most appropriate care for that patient, ensuring that we have those safety backstops so those patients aren't just falling off without being seen, and being seen kind of more appropriately within time. Ooh, apologies, it's skipping to, which is not helpful. There we go. So finally, the third lever is really just offering patients digital patient-initiated follow-up to try and move away from this face-to-face appointments as routine. So that means allowing patients to initiate contact with a service that they're already known to at the point that they need care, rather than a default face-to-face model of routine kind of appointment booked every 9 months, which may be at points that a patient doesn't need that care, or actually if they have a flare-up of their otherwise stable symptoms, they want to be seen closer to that time that they have that flare-up. What that also helps to do is to help free up capacity to see new referrals by moving more patients onto kind of digital patient-initiated follow-up pathways. So the thing to bear in mind here is obviously it can only be achieved with clinical safety in mind. So it may not be suitable for patients that are otherwise stable or have stable conditions. So this is some of the work that we've been doing around dermatology to identify which of those patients would be eligible to move on to a PIFU pathway. And then also building those clinical safety backstops in the product. So reminders to patients and healthcare professionals about which patients are on these pathways, what are the regular touch points that we need outside of patients also being able to initiate care into the service. It's not only good for patients, but also healthcare professionals. So the way that we work at Acurx is we have a centralized space where healthcare professionals and admin staff can manage those incoming requests from patients. And over the last 6 months, the work that we've done with dermatology, we've seen that actually 71, so only 8% of patients submitted a request. So it's not a huge volume, it's not overwhelming. It's actually far fewer volumes than they typically get coming through to phone calls for simple requests as well. Of those, 39 were medical, 32 were admin, so it could be dealt with by the most appropriate staff member there. And half of those requests were resolved digitally without needing a booked appointment. And throughout that process, we've been collecting feedback from both staff that are using it, clinical and non-clinical staff, because often there's a focus on clinical staff and actually doesn't take into account the administrative burden of managing these appointments, as well as the patient experience. So anytime that we work in this way, we try and make sure that actually we've got all the key stakeholders that are giving feedback so that we can iterate on this process throughout. And I just want to take a moment to talk about kind of our partnership approach and our work with Trust. So we're very motivated by the value that comes out of working together, both for the organisation, including co-developing products or improving the number of users of our software and the experience of patients. So we work directly with those services to understand what your current challenges are, what are your kind of operational priorities, where are some of the broader cultural issues outside of just deploying tech, and how can we support to kind of work with services to reassure and build that confidence in using Acurx. We're very much a partner and not a supplier. So our vision of joining up communication across healthcare and really making it easier for healthcare staff to communicate to patients and with each other really only happens if we work very closely with those services. And so we really invest in those relationships. And significant additional resource as well throughout. So it's not kind of, you know, you've agreed to a tech, you've deployed it, and then we're gone. We want to continue to improve and add value to the services that you're using and how you're using Acurx, and making sure that actually we're not solving problems in silos, because like I said, a problem solved for a healthcare professional that doesn't also solve a problem for a patient doesn't really achieve very much. So we give Trust very dedicated support throughout that entire process. So you will have product development support, and that you will know the team who's kind of building the products. That includes the product manager, the technical leads, and then they'll work directly with their compatriots on the Trust side to make sure that we have the context and we're building for solutions that will actually work. We also have a dedicated transformation implementation team who will assist with training and rollout of Acurx, and will hopefully help to scope and scale any future work, as well as do that ongoing evaluation and monitoring progress. So we try and set kind of agreed metrics of success with you know, shorter term pilots or longer term work that we're doing, and making sure that we're consistently reporting and creating those channels to kind of surface any issues there. We also have user support specialists that work directly at Acurx. They're a wonderful team, and they troubleshoot in product. So if, for example, someone's using Acurx, whether that's a patient or a healthcare professional, and they get stuck trying to do a thing, they can come in and come online and chat to one of our user support specialists, who will typically respond in 5 minutes. And these are humans, these are not bots. They're a fantastic team. They know the product. They can help kind of resolve issues there and then. Also to try and reduce some of the dependency on your local IT teams who are trying to move a huge volume of work as well. And the other thing that we have is specialist advisors. So Amy and Sandy touched on Tori, who's one of our behavioural scientists there, who's phenomenal. But we have in-house clinical support. So we have clinical leads that work at Acurx. We have a behavioural scientist, and that's really to try and actually make sure that we are doing all of the things that we want to do and doing them with attention, but also making sure we're keeping clinical safety at the heart of everything we do. Because of the volume of patients that we interact with, 58 million patients, we cannot oversee, we cannot undermine kind of clinical safety. So it's embedded throughout the kind of product development piece. We're also really mindful of information risk and security. So we have fantastic CISO, Diane, who's brilliant, and her team to make sure that we're meeting all our regulatory compliance requirements and working with NHS England and others to make sure that we're really building and embedding a culture of data privacy and data minimization by design. And this kind of elective recovery project with UHL is really one example of that innovative partnership. So Amy and Sandy are fantastic. We couldn't have achieved the success that we've achieved at UHL without them. And we meet monthly with our clinical, technical, and operational representatives to review that progress against objectives, ensure that technical alignment, identify any clinical risk, as well as brainstorm and co-develop kind of those future ideas. So we think it can provide inspiration, hopefully, to other trusts who are looking to reduce their elective backlog through tech. And we'd love to work with more of you, and we're very flexible in the way that we work. And we're really led by these relationships that we have with services, with kind of senior stakeholders at trusts, to make sure that we're delivering value in the work that we're doing. So I'm going to pause there. Thank you so much. If there are questions, please do pop them in the Q&A, because like I said, we do have plenty of time for the questions now. Just here, the QR code that you see here will take you to our waiting list page, so you can get in touch with there, as well as read more about the work that we've done. And we've got the partnerships email there, as well as having Rosie and Bratton on the call to help. So I can see one. I'm just going to stop sharing to bring us all back onto the screen there before we go into the Q&A. There we go. So I think we've got one question that's come through which said, hi, were patients placed on digital PIFU automatically transferred, or were patients able to opt into the digital PIFU pathway? Amy and Sandy, I don't know if you want to take this for UHL, and then I can feed into what we've done at other organisations.
So we did an opt-in. So basically, we sent out a text. Initially, we sent out a text which said, according to our records, you're on an overdue default waiting list. Do you still want your appointment? Would you do you no longer want your appointment, or do you prefer to be on a patient-initiated follow-up? And you put in the text a brief explanation of what that was. So it was an opt-in, and we had a high number of patients who would prefer the PIFU module actually than for a further appointment or be discharged. So it was opt-in, not opt-out.
And that's broadly what we've done across other services as well. So typically we identify which patients are eligible for digital PIFU pathways, and that's working very closely with those services. So like I said, they have to be generally on kind of quite stable conditions. Those high-risk patients that you have may not be eligible for digital PIFUs, and that's entirely appropriate, and we'll think about other means to kind of monitor and keep in touch with those patients. For digital PIFU, it'll often be those more stable patients, which is by and large the large bulk of patients. And there's the before we typically move them onto the pathway, there will be some communication with them to say, either we're doing this, here's more information, and here's how you opt out, or would you like to opt in as well? So lots of different ways of doing it, but very much led by patient preference and also an understanding of whether the patient will be able to engage digitally in that as well. And if they can't, then we have kind of proxy methods to ensure that actually they can still get in contact with the service digitally, but it may not be led through them, and I can talk a bit more about that if relevant. So I think there's a question around what nationalities are there in Leicester. I don't know whether that's one for you, Amy and Sandy.
Yeah, I haven't got the percentages, but we know that Leicester is one of the most diverse cities in the UK. And when we're asked to produce information, we're asked to produce it with a reading age of 7 or 8. So again, mentioning Tori again, big shout out to Tori. She's helped us word our texts, so it's like really simple language, and basically you can tell from our response rate, which is now our last validation, our response rate was over 80%. That isn't a barrier, because patients can either go on Google Translate or show a relative or friend or whatever, and they are managing to reply to it because it is simple. So it hasn't proved a barrier. One of the things today, we're also with them, we're doing deaf awareness training in the trust at the minute, and one of the comments from some of our deaf patients is actually they'd rather have a text, because they can respond to a text where if somebody's ringing them, they can't hear them. So actually the text message function and the questionnaire is working really well.
Yeah, and just to add to that, Satya, as well, we've not stopped doing what we normally do. So our letters are still going out as this is just an additional way of communicating with our patients. So what we did for those patients before that English is not their first language, they still will receive that letter with the option to get in touch if they require that in a different language. So this is in addition to what we already do.
Fab. And I can definitely add context on the product side. Translation is something that we're building in. So we started with kind of the online consultation platform for GP practices where patients can translate what they're submitting in their own language. That will be expanding, but it's work that we have to make sure it's validated, it's clearly understood, etc. So a bit earlier in that journey, but yes, something that we are very mindful of. What we don't want to do is exclude more patients through the use of digital means. So definitely something that we are factoring in as we kind of build our product development. And so next question that I can see is, with the NHSE 12-week deadline fast approaching, how soon could a trust be up and running with administrative validation? My answer to this will be weeks, but I'll let you, it's literally a matter of days, weeks. So the platform is very simple. It's integrated with the NHS mail single sign-on as well as the personal demographic service and NHS Find. So to be able to get in and to be able to message a patient is you could do that today if you went to web.accurx.com. And in order to do it, work more closely with services really depends on what the capacity in the service is. But I'll let Amy and Sandy give more of a nuanced answer to that than my probably optimistic one.
So before we had batch messaging, literally you can create lists on Accurx, and like Satya says, if you've got a Accurx web account, which any health professional can have, you can just create your list. I think there's you can have a list of up to 250 patients, and then you can start messaging them individually. It does take longer, but Sandy and I, we used to race, didn't we? And we could get messages out to 50 patients in 6 or 7 minutes. So it's not as fast as pressing a button and the message going to 5,000, 10,000 patients, but it is still doable. So yeah, like Sachi says, if you have your Accurx account, you can start the validation instantly.
Well, I see another question around what other clinical questionnaires do we have available? How have clinicians and admin teams found using Accurx in general? So I'll split those two out. So other clinical questionnaires that we have, and we build quite a few in-house. So we built lots of primary care around more traditional kind of primary care routine condition monitoring, as well as on the secondary care side, we're working with services. So obviously where there is a copyright in place, we will work directly to kind of access and have access to the copyright. That's one of the things that we consider. But broadly, we can work directly with services. What we tend to find is that everyone has the questions that they ask in paper form, or they wait until a face-to-face review, and often you can convert that digitally to get that information. So there are lots available already. There are more coming. It really depends on having access to those services and working directly with them, and then doing that validation piece to make sure we're really comfortable in translating into digital format before we get it out. So whatever you can imagine, we can build, as well as giving you the ability to build it yourself. But we want to make sure that it's done safely and with a clear use case in mind. That's really the things that we consider. How have clinicians and admin teams found using Accurx in general? I'm going to hand that one over to Amy and Sandy.
So the admin teams absolutely love it. We've had some resistance from managers thinking, when we've gone in to speak to the services, the manager's like, oh no, the admin staff are so under-resourced, they can't possibly learn anything new. As soon as we've actually gone in and physically shown the staff how to use Accurx, get them set up with an account, you can see the relief on their faces, and they've not got to take all these phone calls anymore. They've not got to get abuse from some of the patients. They can just send out messages. They can allow the patient to reply. The patient can reply when they want to reply, and the message can be dealt with when the admin staff needs to or wants to deal with the message. So feedback from admin in particular has been fantastic. Clinicians who are quite tech savvy absolutely love it. So we have some really got a colorectal surgeon, Sanjay Chowdhury. He's got all his patients. He's created lists of all his patients, particularly his surveillance patients, and he just messages them regularly. They message him back. So he loves it. We've also got a thoracic surgeon, Ed Karuna. He's completely changed the way how he delivers his follow-ups for some of his cancer patients. So before they used to have to come into hospital for test results. Now what he does is he uses the time that they would come in for a test, that he would sit with his registrar, go through the test results. If everything's fine, he'd send the patient a text so they don't have to come in for their results. If the test results need discussing, then he'll call the patient in, but the patient then doesn't have to wait for the results, so it's a much better patient experience. And we've got an event in November where some of the clinicians who are using the system really well are going to showcase what they're doing, so hopefully get other clinicians involved. So I think once people see how the system works and see how it can benefit them and patients, they want to snap their hands off, but it's actually getting to them because they are busy and sometimes they do think, oh my God, this is more work. Oh no, I can't possibly cope. But as soon as they've seen it and see how it benefits, and also seen the feedback from patients, it has been received well.
And just to add to that, if there's any additional support or training that Staffy, we're always happy to be on the ground as well to run those training sessions. So Ali, who's worked very closely with Amy and Sandy, has done quite a few of that going around from service to service. We have lots of volunteers at Accurx to spend time at hospitals, even if it's just getting people set up on Accurx. So lots of people get very keen to visit. I think we'll wrap up there because I think we've answered all the questions as far as I know. Thank you so much, everyone, for joining today. If you do obviously have any questions like that, please do drop us an email, partnerships@accurx.com, or have a look at our website. And we will share the slides after. But yeah, thank you very much for joining, and thank you, Amy and Sandy, as well.